All right, we'll get started for the evening. So welcome everyone to what is the fourth installment in the VRHC Virtual Speakers Series. The topic for tonight is medical workforce, challenges, solutions, and the distribution with a focus on solutions. So my name's Sky. I'm the Vice President of the Rural Doctors Association of Victoria, and I'll introduce this fabulous panel in just a moment. But before I do, I'd just like to pay my respects and our respects as RDAV to the traditional custodians of the lands on which we all meet. The panel is diverse from all over the country, so we're meeting from multiple different lands, and I'm sure our attendees are from a variety of lands as well. We'd like to pay our respects to elders past, present, and emerging, and also extend that respect to any other First Nations people who might be present with us this evening. So tonight we have a panel. We're going to go through and introduce each of these amazing panelists, and we've got a few pre-prepared questions that we're going to start the evening with to kick off the discussion, but then we'd very much like to hear your questions so that we can answer those. So we'll go through the panelists one by one. I'll ask each of the panelists to give a brief introduction of themselves, and then we'll get started. So first up, we've got Dr. Jessica Painter.
Hi everyone, I'm Jess. I'm a PGY2 doctor at Bendigo Health in regional Victoria. I'm not on any training program at the moment, and I'm the current co-president of our HMO Society at Bendigo Health, and I'm originally from Swan Hill in northwest Victoria.
Thanks, Jess. Next up, we've got Dr. R.T. Lewandowski.
Who's technically challenged, sorry. So yeah, my name is RT. I'm a US trained rural generalist. I was previously medical superintendent of a hospital in Queensland called Kinguroy. And I currently am as an SMO in Innisfail and Cairns, where I do obstetrics and endoscopy.
Thanks, RT. Next up, we've got Ms. Therese Tierney.
Therese Tierney, thank you. For the context of tonight, I'm Victorian, and I've been a CEO in Metro, Rural and Regional Health Services, and often had to deal with the conundrum of medical workforce.
Thanks, Therese. Next is Dr. Paul Mara.
Thanks very much, Sky. I'm a rural generalist practitioner in Gundagai, New South Wales, been there for 39 years. Previously president of the Rural Doctors Association. For my sins, I run an accreditation agency and have been in about 1,200 practices, both rural and metropolitan, over the past 12 years. Yeah, I've got a long-term interest in workforce. I co-authored, did the research with John Humphreys on the RDAA Viable Models project. And I finally convinced the Murrumbidgee Local Health District to move in a different direction with workforce.
Thanks, Paul. Next, we've got Ms. Hayley Bell.
Thanks, guys. So I'm from the Rural Workforce Agency based in Victoria. So I myself predominantly focus on workforce planning and some of the advocacy functions of the agency. So overall, we kind of focus on health workforce maldistribution across the GP and the allied health space as well. And we also focus on supporting access to health professionals for our rural communities, as well as supporting the kind of training and upskilling requirements of our health practitioners as well.
Haley. And last but certainly not least is a face that might be familiar to you in RDAV, which is Dr. Rob Fair.
Thanks, Sky. My name's Rob Fair, President of Rural Doctors Association Victoria, rural generalist, FACRM, living and working in East Gippsland and Central Gippsland, where my work includes anaesthetics and emergency. And I've got an interest across all types of rural generalist issues, and most particularly including workforce and the future of our rural generalist workforce.
Thanks, Rob. So as I mentioned, the purpose of tonight is to consider the challenges to do with the rural medical workforce, but actually more important than that, what are the solutions? What makes one location more appealing to junior doctors, for example, than another? And you know, how can we retain staff out in the regions, in our rural and remote areas? So most importantly, we do want to answer your questions. As I said, there are a few pre-prepared questions that we're going to kick off the discussion with, but we want to hear what you want to say and want to know. So can you put your questions in the Q&A chat box? The function is down the bottom of your screen, and we'll get through as many questions as we can. So to kick off the evening, we might start with Jess. She's our junior doctor on the panel and rural health advocate. To set the scene, what would you be looking for in a practice, hospital, or community when you're thinking about applying or accepting a job?
Yeah, thanks for the question, Sky. The main thing that I look for is the culture and the self-acknowledged actual reputation of the hospital or place or like centre that I'm applying or interested in. I'd want to know like what they think of their culture personally and what they think of their reputation. I want to know what they think they're good at and also what they think they need to improve on, because I think every centre has something that they need to improve on, and acknowledging and working towards improving that and having engagement from new staff to improve that is really important. I would like to know what range of exposure I can get from that hospital or centre. How diverse is it? What other services are there? What can you and can't you do there? And the experience of seniors in terms of teaching and engagement, and how they're going to use their seniority to support myself and believe in me to get where I think at that stage I need to go, and how can they mentor and support me to do that. I didn't really want to touch on payment or like income, just because I don't have a great understanding of that at this stage in my career of moving from hospital to say GP centres. So I didn't want to speak about that, but I'm happy for other people to speak about that. But those were the main things, the level of experience and what they think their culture is and how they're improving, and if their willingness to operate in an environment of change that's commonly thrown around. But I think in the last 18 months, that's probably what their flexibility is to support trainees during this changing environment and changing requirements as a junior doctor is quite important to me.
Thanks, Jess. And I guess just to note as well, the purpose of this discussion is to be open and honest about, the things that really are barriers for people. There's no point in us all just saying what we think we all want to hear. And I think it's actually a really great point that you raised, which is, at your stage in training, you might not be familiar so much with, financial issues, but you are aware that there are financial issues, and maybe that's something that actually needs to be considered and addressed. Rob, we'll move on to you as a senior rural generalist who's worked in both WA and Victoria. It's a similar question to set the scene. What do you look for when you're considering your next career move or job?
Thanks, Sky. Similarly to what Jess said, I look first and foremost, I guess, to if I decide I want to live in a particular region, for starters, I guess I want to look after the family's needs first. I've got young kids, so that's obviously a significant consideration. Education, access to to work for my partner. Education's looming now as a bigger one for me as my kids approach high school age. But very similarly to Jess, I look closely at the culture of the place I'm going to, and the rural generalist culture specifically too, because as rural generalists maybe doing procedural work, we want to make sure that we're going to be able to continue doing our procedural work in particular into the future. So that might include anaesthetics, obstetrics in particular. Other fields such as emergency medicine, we know we're always going to have work, but specifically anaesthetics in my case is an area where we actually are finding it quite tricky sometimes, finding the right balance of work and how the work is distributed amongst different doctors. So access to procedural work and transparency in how that work is also distributed amongst different doctors, whether it be trainees or senior doctors. So, and I've noticed some significant differences from say, for example, salaried jobs in Northern WA and Victoria, where in salaried hospitals, there's a greater degree of transparency and everyone's allocated work more or less equally to situations in Victoria where you have possibly groups of practices that might actually own procedural work. So that then, for an outsider or for a new person, becomes potentially quite a significant issue. The other issue in Victoria, for example, compared to other states, is that you have different arrangements in every town, so it becomes a bit confusing. So beyond that, talking about the culture, I guess I'd like to see a culture in a hospital I go to where, with a commitment to education, to quality and safety, to greater goals. So where doctors are not just doing their narrow scopes of practice, but where you can see evidence that doctors are really going above and beyond and are really trying to make their communities better places, or involved in their communities. And, you know, professional development opportunities, I'd mention an ability to pursue other career interests. So health services that might, for example, allow you to take, say, you want to go and work in the Solomon Islands or PNG for 6 months or a year, that there's those kinds of exciting and adventurous opportunities are possible. Maybe not during COVID, but maybe in a few years' time.
Thanks,
That'll do
Rob.
for now.
Thanks. We'll throw it over to you, RT. So, RT, you've already brought up Kinguroy in Queensland, and we understand that when you were in Kinguroy, you managed to recruit and fill all of the available positions. So, what would you consider some of the key elements that made Kinguroy a really attractive place to work?
Yeah, thanks, Scott. It's an interesting question because the truth is it wasn't attractive so much. It's one of the lowest socioeconomical communities economically in Queensland. We had an old building that was not fit for purpose. We were relatively isolated, high volumes of disease. The GP practices had empty rooms. So like from an outside perspective, it wasn't desirable, but we did manage to recruit everybody. And so I guess I had a lot of things in my favor. I had a secret weapon called Peter Rutherford, who was my boss at the time. And she was happy to think of, she was never happy to waver on our target, but really happy to think outside of the box and take lots of possibilities. And if she hadn't already thought out of the box herself. But why did people come then? Why was it desirable? I went ahead and called some of my team to answer the question, because it's a good one. and what they told me was that they were really attracted to the fact that we did have an RG model. And so they could use a full scope of their training. They felt like they were really well supported and really secure that they weren't going to be left hanging in a crisis. They felt that we had a good focus on education, and in the medical team and culture was good, and they had good training exposure. So I'm trying not to talk too long, but so how we did that. We partnered with all the GPs. So when we got there, we met with every practice in town. They all had empty rooms, and we came to an agreement on how we would work. Flexibility-wise, we co-appointed pretty much everybody. So they worked in the practice and in the hospital. We used every model you could imagine for employment. So we had people who actually did not work for Queensland Health at all, who covered shifts in the hospital. We had some people who were on a VMO contract who would cover shifts maybe 4 days in a fortnight. We had people who were senior medical officers. They were committed to us for part-time and to the GP practices for part-time. Whatever worked, if we could make it work, we were flexible to do that. So we had all that type of thing. We also were able to offer flexibility in rostering. So because people did come with young families and older families, and there were different expectations based on their spouses or the kids, and we were able to work with that. We saw value we weren't fixed to a roster or to a fixed day you had to do. Everyone didn't have to do a certain thing. We really our team was valuable, and we saw value enough so that we could create flexible environments. We also made sure though that we had fair environments. So Rob, we didn't, nobody owned anything. Everything was fair and equitable, not even, but fair and equitable. So some people liked certain things and didn't like other things. And we managed to meet as a team and come up with a way to make everything equally split. And we were an RG hospital. And so we worked towards making sure everyone could use all of their skills. We worked up to the point where we were operating some sort of theater 9 days a fortnight, from going from emergency theater only. We ended up, so the anesthetist got exposure, our rural generalist surgeon got exposure. We switched things over. So any visiting service we had, we tried not to do anything with the visiting service that we could do with an RG. And we asked the visiting service to do higher end things. So we could actually bring both the support to our RGs, but also a higher level of care to our community. We incorporated the GPs in their advanced skills, or some had even trained before that was such a thing, but they certainly were incredibly skilled, and we incorporated them into the service. They covered quite a bit of our obstetrics care and some of our anesthetics care, some of our emergency stuff. We became a medical community as opposed to an us versus them type community. We focused a lot on education. So again, partnering with the GP practices, education was sometimes expensive to offer, but we split it up. So we all had people that we needed to educate. And so we divided time between the practice would offer education to everybody. We would offer education to everybody. We invited everyone to pretty much everything that we did. And we formed partnerships with the RTOs, with the medical schools. We actually built a campus on Kinguroy campus, and we started training, kind of growing our own. In fact, some of our best medical officers were people that we grew locally. They came over initially as second-year PGY2s and ended up as senior medical officers and GPs in town. But we had students, interns, residents. It was a lot of work, but we ultimately got that. And then we trained people. If there was an opportunity for train the trainer, we sent our medical officers off to do it. And we started offering education centers, which let us deliver quality care locally. And the hospitals around started sending their officers over to us to do the training for things like neo-recess and prompt, key crisis resource management, anyway, stuff like that. I could talk for a long time, but we also made sure, though, the last thing is we were very aware of what we promised people when we brought them on, and we honored that. We didn't promise things we couldn't deliver, but we did. We wanted to make sure there was a work-life balance. We wanted to make sure there was a fair distribution and that there was a support. Nobody was left hanging. So we did have the team, even no matter what level you're at, had tremendous ability to offer care to patients and part of the team. And we let people do that to the extent that they were able and comfortable. And we helped them work to the point where they were comfortable at that senior level. But when they weren't, we provided the support that they needed. We made sure that they had appropriate backup or were rostered in a way that there was someone there with them. Lots of things that we did, and I could talk forever. Anyway, that's the stuff we did. And that's why people came. We did have a good team. We supported our team. It was a team that we cared for and cultured. And we weren't fixed on here's what things had to look like. We were very flexible, and people could suggest how things ought to look. And if it worked, guess what? That's what we did.
Thanks, RT. I can see that there's a lot of questions starting to roll in, and we will get to those very shortly, I promise you. And there's one in there for you, RT, already, I can see, about the Kinguroy model. We'll come back to that. But first, we'll flick it over to Therese, just for a quick question. Often bureaucrats get blamed for everything that goes wrong in a health service. As a CEO, what can be done to support the recruitment and retention of the medical workforce? What have you seen in your experience that's actually been quite successful?
So look, my response is in the context of being a Metro CEO coming into the rural and having to learn very quickly. I had not worked with GPs. And I went to a very small rural and then went to a Group B, which was transitioning from a GP VMO model to a growth factor where it outgrew that model. So they're the sort of contexts that I'm talking about. I think it's important, regardless of whether it's medical or not, that the health service has a clear vision, and it has an exciting vision. And it's actually making sure that it actually fulfills that and keeps moving at a pace where people can see they've got a future. And I think that's very important. I think too that I inherited a problem that there was no medical pathway because of the funding models. The intern rotation and the PGY2 positions were funded, but not beyond that. So I had to make a deliberate choice about how I allocated money to create a medical pathway. And I seized an opportunity through a community-based intern program and switched the intern programs around to be based at Bairnsdale with other experiences versus taking metro rotations completely. So we started to focus on building loyalty, I suppose, to a region or to rural health. in saying that too, when you recruit medical workforce, some of the things that Rob touched on, they've got families and things of that nature. We made a concerted attempt, and you hear it in other forums, of trying to build a social life for people that were coming as strangers into communities, particularly in the small rural one that I was involved with, and creating a social life for the first few months until they established and finding out what was important and delivering on it. And a lot of that importance was training, and that was my first dilemma. I felt totally adrift. I think in more recent years, the pathways are clearer, but I felt very alone because, as you know, the Victorian system is a collection of, agencies. And I found that very difficult to work out how to support the training as we went along. But to me, I really think in the rural environment, what I've learned is that we need to be respectful of the old GP VMO models and look towards hybrid models that actually complement each other. So the models that we started to create were respectful of that. But one of the dilemmas has to be too, though, that if you're a CEO and you're looking at your risk profile and your succession planning, your medical succession planning is all based in private practices in your community, it is actually a scary place. At what point are they going to engage with your next anaesthetist, your next GPO? How are they, going to help that sort of process? And I think that's the respectful relationship that has to be both ways when you go forward, because that is quite a scary place. So I think that that I actually tried a number of models, particularly in the ED, and then settled on an ACRM as my preferred way to go because of the very strong generalist skills that seem to create, which when you think about the scope of practice of a Group B rural health service, that is the range that actually seems to fit particularly well. And but also I do look at the individuals, because I do believe some individuals do better there in the rural environment than others, and they're the ones that have more confidence around some of their decision making with different types of support than the traditional ones. So I think that my experience is that as bureaucrats, we actually do think about these things and we're passionate about those things. And you will find that many bureaucrats, when you engage with them, with the problem, will do what I've done, which was bankroll a different model and change. And I actually put my hospital in deficit for a period of time to be able to create the model, because in Victoria, the costing models are averaged. And when you're a growing facility, it takes a while for the department to catch up with that. So you have to embed, I think, in management, this commitment to bankroll the future.
Thanks for that. That's a great quote, I think, to take away, bankrolling the future. Paul, we'll throw it over to you. You've contributed many things to the movement of RDA, but the latest effort is actually the single employer pilot that's happening in Murrumbidgee. Can you tell us about it and give us some insights into the early feedback from practices, registrars and the district?
Yes, I'll do that. And then if possible, I'll just go back on some of the workforce concepts, because I think what we have out there in the general practice, the rural doctor and the public arena, is a lot of misconceptions about what the real problems with workforce is. So the first misconception, I guess, with the sole employer model is it's not an industrial model. And people are attempting to take it as an industrial model. It was basically conceived as a workforce model. And it wasn't conceived overnight. It was something that came about through a lot of experience, and it had a lot of the elements that people have already talked about tonight. And it looked at the evidence and the research when we tried to do it. Now, I spent 5 years attempting to get the Murrumbidgee Local Health District to look at this model. And the reason it took so long was because there wasn't a real realisation about what the potential in the communities out there actually were. It was only when they started to see people bailing out of country towns and towns going on bypass and the increasing costs of ambulances and things starting to get blown out, that they recognised that they had a responsibility to those communities, not just at the hospital level, but at the primary care general practice level. And so the three elements to the model are essentially the first element, which is a needs analysis in communities. Now, this is not a needs analysis that looks at, how many hypertensives you've got or whether you want to have obstetrics, that sort of thing. It's looking at the fundamental challenge in workforce in rural communities, which is how do you service a town on a 24/7 basis, providing comprehensive and continuing care? I mean, that's the fundamental workforce challenge in our rural communities. And what's required to do that, and what sort of model would fit around how that's actually delivered. The second element was the training program in itself, and the training program was a 6-year training program. So it started to bring it up to the focus of a specialist training environment. And in New South Wales, the New South Wales government allowed us to provide a job opportunity for a trainee after their second year to have 4 years guaranteed employment, similar to other specialists areas. The third element is what actually happens when you train these people up and you provide them with the skills. Do you just sort of send them out there and say, go to it? Well, no, that's not the answer. These doctors become part of that community, part of that establishment, and have the same status as a specialist in rural medicine as what a specialist in cardiology or whatever would happen. I can go into more detail about the elements of the program because it's very important that whilst the program has considerable flexibility, it doesn't have an open-ended sort of, I'll do this and I'll do that other thing. I mean, it's something that you have to maintain the program because each year is structured around a particular way. Importantly, the program doesn't create anything new. It uses the curricular basis of the colleges that is already there. It has the established training mechanisms that are there. It looks at the various arrangements that registrars are working under, and it integrates all of those things. But what it does is that under a sole employer model, it allows the trainee to move seamlessly between the hospital and the community-based training terms. And so under the current GP registrar arrangements, there's not that flexibility to actually move. And so I think flexibility has been something that has been brought up here. So some of the elements and some of the ideas we got from the Queensland rural generalist approach. But in Queensland, that was basically a hospitalist-based approach, whilst it is moving more and more into the general practice environment. In New South Wales, we have a VMO model, and the whole idea of this is to evolve that VMO model, I think, as Therese talked about, to something that provides not just so much flexibility, but the opportunity to actually meet the needs of the community rather than having to meet the needs of an individual fixed model, be it a Medicare-based fee-for-service or a straightforward VMO model. So where do we come into issues? I mean, there's never been a good idea that hasn't been stuffed up by someone. Basically, I think the registrars want this. And why do they want it? Well, if you look historically, where have all the rural doctors gone? When I graduated, 30% of my cohort from my medical year turned up to be rural doctors. So where have they all gone? They've gone into the specialties. In particular, they've gone into ED medicine, emergency medicine. And so when you start to analyse why they do that, it's because they've got a job, they've got constrained working hours, they've got a high reputation and status within the system. They actually control entry into many of the hospitals, and they can go home when they want to go home. And so there are certain elements in there that we need to factor into if we're going to compete with that sort of a model. And the opportunity to have flexible remuneration engagement relationships, extending that salary-based component, if you like, for the length of the training is very important. So the offer has been taken up quite enthusiastically. In fact, we've now got 5 people there. We'll be advertising again. If the Commonwealth Department of Health had moved away from this sort of, it's not my responsibility, it's the state's responsibility, it's not the state's responsibility, it's the Commonwealth responsibility, this sort of in and out fighting and pretending that there's sort of a double dipping arrangement because people employed by the Commonwealth are actually generating Medicare revenue while they're working in the practice, we would have had 20 people in the positions. It ramps off the established strategy, which I think has probably been one of the better strategies, in the regionalisation of the undergraduate education. And so people going through that undergraduate education in Wagga, for example, are selected. Many of them come from the regional areas, and they see this as an opportunity to move into a practice with the same status, training, prestige as what other specialties would be. So that's a brief sort of overview of it. But if I could come back to the core elements to it, I mean, the research that John Humphreys and I did with the RDA viable models, it clearly showed that sustainability in practice is based on 3 core domains. There's a professional domain, which looks at the education, training, and relates also to the work requirements that the doctor has to do. I mean, how much on call are they having? Do they have flexibility about time off, that sort of thing. There's the structural issues in terms of, do they have adequate infrastructure? Do they have adequate systems that are helping to manage where they're working? And they're very important for the sustainability. And the third thing was the industrial and remuneration aspects. And I'd have to say, it's not so much the level of the remuneration or the incentive component, but it's how that remuneration actually reflects the work the doctor's doing and how that actually builds the capacity. Too often with incentives, it's going to an individual doctor, but it's not actually building capacity in the practice. And that's what we need to do. Now, if I was to walk down the main street of George Street in Sydney, and I asked everybody, do they need more doctors? The answer would be yes. But what this belies is an understanding of the real workforce imperative, because Australia has virtually more doctors per head of population than every other country in the world. And so the workforce dilemma in the rural areas is how you have enough capacity to service in a sustainable level the needs of that community on a 24/7 basis. In the city areas, the workforce perception is driven by business models. And we've had an evolution of business models moving from the mum and dad general practice area to the corporate movement, to the built-for-profit evolution. And now we're seeing a different model coming about, which is the built-to-sell model. So there's a lot of money going into building general practices up purely for the notion of taking overseas money and floating on the share market, these sort of things. So it's built to sell. And that all comes down to the economic relationships. Now, unless we understand that, we won't know why all these extra graduates we poured through the medical schools, all these extra doctors we brought in from overseas, they're being sucked up by this system in the city areas like a vacuum cleaner. Because if you build more practices, as a business manager, you need more doctors to service that business need. And particularly when you've got a built to sell model, that's where all the doctors are going at the present time through the general practice arrangements. So in fact, we're funding people in our system to build these models which really aren't meeting health needs, they're just meeting business needs in those metropolitan areas. And I think it's important that we understand that. I think the second thing that I'd really like to kill off as soon as I could is this notion that was spread out early on that in order to get a person to go to a doctor to go to a country town, you had to have this thing called easy entry, gracious exit. In other words, you had to give the doctor more and more incentives. You had to provide them with all the services there. And when they left, the doctor would take everything and not leave anything behind for the community. And I think what this does is it creates this competition in rural areas. Back in the good old days, you'd get a Hyundai or a Corolla, but now you've got to offer a doctor a Mercedes to get them to come to your town. And there's this notion that incentives are the answer, and incentives aren't the answer to this thing. What is the answer is really showing that these towns have a worth and a value of themselves, and they're all very, very important out there. And really, I think there's not that understanding that these places are good places to live. They're exciting places to live, and they've got skills and expertise right across those communities that are important. I think it's something that we need to be selling, these rural towns, rather than just treating them as basket cases. And that's what this easy entry, gracious exit, which is still promoted out there, particularly among some of the workforce agencies, that we've got to give you incentives to go there, or we've got to do this to go there, when that's not the answer. So there are a few sort of 39-year insights into rural workforce.
Thank you, Paul. Thank you for that. I think you've given me my new motto. There's never been a good idea that someone hasn't managed to stuff up. So that's a great take home from quite a lot of pearls of wisdom. Before we open up to the questions, and we've got a lot of questions coming through in the various forms, I just want to throw it over to you, Hayley, and just ask, from a rural workforce perspective, what does rural workforce see as the priority at the moment?
The priority at the moment for us is really on access and continuity of access. So focusing around how we can support the medical workforce to get into rural areas through, through all stages of the career. So from that early career, from that engagement with the future workforce at the school kind of level, getting people interested, and then supporting down the track through a number of mechanisms, and also providing the supports that are required in terms of some of those things that touched on, in terms of training and upskilling and supporting those requirements, and how we can be more kind of innovative and agile to support the workforce when the communities are quite reliant on, a lot of the time, solo practitioners, how we can go about that.
Perfect. Thank you, Hayley. We're going to open the floor to questions. If you want to submit a question, you can put it in the Q&A function or the chat function at the bottom of your screen. So we'll start with a question from Sue Harrison, and I think we'll direct this one straight to you, Jess. The question is, general practice is currently underfunded and struggling to make up for the effects of the Medicare freeze. Doctors are graduating with significant debt. How much is this affecting junior doctors' decisions regarding which craft group they enter? What are your thoughts about that, Jess?
Yeah, I think that's a great question, Sue. Thanks for submitting that. I don't have the most thorough understanding of the Medicare rebate freeze, so I won't discuss that. But in terms of being a junior doctor, the most common thing that I have to find myself considering to constantly check myself about is basically the junior doctor treadmill, that you get sucked into some path and there's very little flexibility to navigate off that path, basically, aside from the rural generalist model in the future, to reevaluate your options. So in terms of the Medicare rebate freeze and graduating with a $60,000 HECS debt, which I have, that doesn't influence currently my decision on what career I want to pursue. But definitely this junior doctor treadmill kind of vacuum that we get sucked into. And I was actually discussing this with a colleague the other day. Obviously, in internship, we have mandatory emergency surgery and medical requirements terms. And I was actually discussing the thought that potentially in PGY2, there should be a mandatory GP requirement just to re-engage interest, would be my thought for people who are kind of looking towards their career point of seeing kind of the normal streams that you go through during internship. And particularly in Victoria, unless you do the GP internships, you don't re-enter that GP thought until you've basically exhausted all other options, is basically what I see it as. So yeah, I think mainly the main issue for junior doctors is this junior doctor treadmill that you kind of get sucked into and you're stuck on one path. But I think as you get further down that path, certainly the Medicare rebate freeze and your debt that you graduate with does add up.
Thanks, Jess. It's going to be a bit of a rapid fire of the questions because we've got a lot, and I think that they're great questions, and I want to introduce some more to the conversation. So we're going to move to the next question, which was from Shane Boyer. Thanks, Shane. Which is, sounds like a fantastic system, RT. Congratulations. What types of roles were you able to provide for the non-procedural advanced skills like PEDS, mental health, and PELCare, and how were they employed?
Yeah, that's a good question. So our non-procedural advanced skills that we used at Kinguroy that we had medicine, pediatrics, Indigenous health, and emergency, and how we used them. We had one who had emergency as an advanced skill, and what I did is I put him in charge of the emergency department. So he was the one that we went to help guide our procedures, to make sure that we're up to date, to help direct training, to arrange our very poor fit for service emergency department in the best way to allow flow. But he basically helped run our emergency department. That was his portfolio. The pediatric advanced skill, I had one of those. And then I had two others who had interest in pediatrics. One had a child health certificate and one just had interest, but we established a pediatric clinic. We lost, sadly, to death our pediatrician for the area, and so we didn't have a visiting pediatrician. So under PETA's guidance, she had this great vision. We started a pediatric clinic and actually saw more patients than we had before. But what we did is we had a rural generalist who I arranged to have supervision from Toowoomba in a relationship. We had Toowoomba send a visiting peds about once a month or so, but we had the rural generalist there every week, and she could run a peds clinic with referring on or questioning or whatever, but most of the time we could see them there. And then we ended up having 3 people involved in that peds clinic. Our internal medicine, she helped. We had 44 inpatient beds. Some of those are obstetric beds, but a lot of them were medicine. So she helped to some extent tailor our rounding and our decision making. We could go to her for more advanced things, and she had a better relationship, pretty direct relationship with the physicians in Toowoomba. She also helped us establish a chronic disease management clinic in our Indigenous community of Cherbourg, using her skills. And our rural generalist with Indigenous health spent half his time in Cherbourg and half his time with us. So we found ways to do it. If someone had the skill, we really found ways to use that to the community's betterment and to keep them fulfilled. They earned the skill, they wanted to use the skill. And there's always opportunities to do that. Sometimes you have to think a little bit differently about how you're going to do it, but that's how we did it. I'd hoped to develop the medicine advanced skill a little bit more than we had. Ideally, we were going to set up a consult service where she could be directly related to our endocrinologist and cardiologist, et cetera. I had a physician who was really interested in doing that for us, but then he resigned and never quite got that developed. But there are other things you can do with that advanced skill. And mental health, I was so trying to get a mental health advanced skill, but couldn't get anyone with that skill. But I think our problem really was we didn't have enough of the non-procedural advanced skills, not that we couldn't use them, and we certainly did use them.
Thanks, RT. The next question that's been submitted is from Nisha Cott, and I'll open it up to the whole panel, but we might start with you, Therese, if that's okay. The question is, how do you support IMGs specifically when it comes to the rural medical workforce?
Well, I'd have to probably talk about it in the hospital context, because that's what I know. And I actually see the IMGs as a future workforce. And so I want to inspire them around staying. So I make sure, well, and also I have a vested interest, quite frankly, in safe practice. So it is about not working them to every minute of the day and actually involving them in understanding the mechanisms of quality and safety cultures, what's required. And once again, it's that investment and ensuring they've got supervision. And the struggle is in a health service that's in transition and doesn't have the employed, ED staff, et cetera, and still relying on the GP VMO model. There are so many competing factors, because basically the GP needs to be back in their practice. And so that's a hospital context. But it's once again, I think it's seeing them, it's building loyalty again, because it's a workforce you require. But also, if you take on board someone, you have an incredible obligation for them to leave that experience better than when they came. And for me, it's about teaching about quality and safety and being able to speak up without fear and all of those things that, as a hospital person, I still see in the medical profession. I still see that sometimes that reluctance to speak up because it's not safe, and create that environment so they learn better behaviours. And then I think are happy to stay in the system. When someone is failing and not succeeding, be honest about that, put in some good structures. But in the end, if it's not working, it's not working. And I think it's about honesty. Yeah.
Thanks, Therese. Did anyone else from the panel want to comment on this really important question?
Yeah, Sky, can I comment on
Yep.
that? I'm an IMG, it turns out. So I've got a vested interest, but how we treated IMGs Kinguroy was as doctors, just like our residents or our students or other SMOs. They tend to, they're just like everyone. They come with a level of supervision, and we provided that supervision and support and allowed them to use their skills to the maximum ability that they could. And no different than we would any other resident or registrar. We were upfront and honest, and certainly anybody who needed coaching culturally, we could provide that. But they needed the appropriate supervision. We honored our contract by doing that and treated them just like any other part of the team. And I found that I was treated the same way when I came. I was a doctor in Kinguroy, and I had the supervision that was required by the AMC, and that was provided to me. And I felt like that's what we should do. But otherwise, not really different than I would any other trainee.
Yep, Rob.
Sky, I have to say I've noticed certainly my experience with my overseas trained colleagues recently has been that, look, I really think it's important, as Therese said, I think it's absolutely critical to give them a voice and empower them to speak up. I have certainly noticed that some of our more recent IMGs have when I've probed and looked into it, they're actually really reluctant to speak up, and they're fearful of endangering their employment. They feel that they haven't passed all their AMC exams, and so I think they need really explicit. I mean, RT, I'm not sure if you disagree, but I found that when I actually ask a few more questions, I find that they feel their work situations are really quite tenuous. Their visas are dependent on their one particular hospital health service arrangement. So really they feel extremely vulnerable. And on top of all that, over the last year and a half, we've had the COVID situation, which has been a disaster for them, in the sense that they haven't been able to go and visit their families, or they haven't been able to bring other family members out. So that's made things extremely hard for them. So I think health services can help and empower IMGs by really talking to them explicitly about what they can do and what they should do, that they should give feedback, that they should contribute to their own training. They should speak to, when they start getting involved with colleges, that they should speak to college, they should speak to their mentors and give feedback about what problems they're having, because if they don't speak up, nobody knows. And I have certainly recently, I can think of a few examples where IMGs have just not spoken up, and it really would have helped them so much to speak up. And we have to empower them to do that.
Yep. Paul? Yep.
Yeah, look, I think over the last 20 years, Australia's imported thousands of doctors from overseas. The reality is that there is a policy to actually solve our workforce problems in inverted commas, and it hasn't done it. Now, I think we have to be realistic about that. And I'm not opposed to medical migration, and the comments that have been made in terms of support. They're a very, very vulnerable group. And when I go out to practices, a lot of the time that I'm spent, accrediting practices, having discussions with OTTs to see where they're at. Often they're leaving their families 3,000 miles away in a capital city. They're exposed medically because they haven't got the skills or the support that's there for them. And they haven't grown up in an Australian medical training culture. And so we've set that policy up to fail in terms of getting workforce into the bush, and relying on that without making the structural changes that are necessary, I think has been a disaster, and I think it will continue to be a disaster for those doctors and their families, and for the communities that actually have to take them on. We know that a significant proportion of those doctors in New South Wales, for example, the longevity of stay in a small country town of an Australian trained doctor is 2.5 times that of an overseas trained doctor. And so, they're there basically to get their ticket by and large and head back to the city. And that's not saying that a number of doctors have been very, very committed and have done a lot for those smaller towns. But this is the reality of the situation at the moment. And so, as a policy framework, it is not going to solve our rural workforce issue. And we need to stop abusing these people and start to move into real positive structural changes that are required.
Thanks, Paul. We might move on to the next question. We've got one from Luke Sartor. Thanks for submitting it, Luke. Hi, I'm thoroughly enjoying the webinar. Good feedback, thank you. Can you share your insights into whether permanent secure employment, e.g. by the local public hospital or multi-purpose service, would help attract more GPs and other primary healthcare professionals into rural areas? As GP workforce model is becoming more corporatized, many GPs are moving away from the role of business owner of a private practice and are looking for more security. Does anyone want to comment on that?
Essentially, the Murrumbidgee model takes that flexibility to provide the best of both worlds. So in the hospital model, RG model in Queensland, for example, doctor is employed by the health service. They work in the hospital, and there is increasingly rotation into some of the general practices to provide that support. What we're looking at is not an either-or scenario, but how you actually build flexible industrial models around allowing people to have both options. And that can all work through a sole employer, even through that time, and have those benefits. So, again, I come back to it. We shouldn't be looking at the industrial aspects for the trainee or for the doctor. We should be looking at what the community needs and how remuneration models or industrial models can actually support that delivery of services the best way in those different communities.
Rob?
I agree, Paul. I have to say, Luke, when I reflect back on my time in the Kimberley, working with WA Country Health Service, with a group of mostly procedural, but also, I guess, mostly procedural rural GP doctors. The advantage we had there is that we could work out our total salaried FTE and then work out the community's needs and what the service provision needs, and we could then allocate. We could juggle and be flexible in how we allocated our resources in a way that it seems a lot more complicated in fee-for-service models. And we could also allocate time for example, public health projects, for education projects, and also, things like issues like liquor accord, alcohol projects, and do things in a way that's a lot more interesting and creative, and a lot more flexible that I haven't actually seen in Victorian models, which are predominantly fee-for-service based. I'm not sure if others disagree with me, but it just seemed to me that a salaried model offered a lot of flexibility, I guess, with the caveat that all your colleagues are equally invested and really motivated to use that time, rather than just doing the bare minimum and nicking off home.
Therese, you wanted to comment?
Yeah, I'm probably endorsing a bit of what Rob has said. We went through a process of, we had to build a business case because we wanted to actually set up a GP practice in the town because of that concern I had around control of succession planning, but more so because it was taking 6 weeks to get into a GP in our community at that particular time. And I really looked into it and felt that the model that was what I thought would work, and also I suppose I could see the generational change in GPs and expectations of other generations as well. And the GP clinic model that we wanted to set up was based on selfishly doing a lot of training, so the succession planning was covered around our proceduralist things, but also to have a training pathway and to really, set that loyalty into rural medicine. And we were quite prepared to plough if there were any profits, because it's not particularly a profitable thing, but plough that back in an investment into that so that there was a secure income. There potentially could be some profit sharing, but there was a secure income. But the other thing that's important, when you're looking at communities where there might be the ED or the urgent care centre, there is some benefit in GPs being able to work at the occasional shifts and keep up certain skills they won't in the practice. Because I know in our situation, it was a probably 22,000 type presentation to ED. Occasionally we would be a bit slammed and we would call on our GP colleagues to help us. Now, because we were moving away into the salary model, they were being de-skilled in some of those areas. And so I did put a thing in the comment there. I think communities where there's maybe 1 or 2 medical practices in a health service need to see themselves as the one medical community and actually try to build models around that rather than competitive type behaviours, and share that medical opportunity and burden and on behalf of the community. And I think that means it'll be successful for both the health service and the GP practices.
RT?
Sorry, technically challenged again. Listen, I agree with what's been said. I guess I would just put out there that listening to Jess earlier and talking to my team, none of them really listed job security on their list of why they chose a place. And so I'm not sure that that's the big take, and Jess could speak to that better than any of us, I guess. But the other thing though is I think when you're looking at models to meet the needs of a community, I feel like there's not an answer. I don't think there's a model that will fit every community in Australia, or someone would have figured that out already, I think. I reckon that the model that would work is a flexible one. So we're certainly, I think the single employer model is not a bad one. I think the shared employment is not a bad one. I think the VMO model is not a bad one. I think for different communities and even for different people, that probably the answer is all of them or some of them. And I think probably the best way to meet the needs of a community and of your individuals, if you want to employ great people like Jess, you probably need to think about what suits them best and let your model adapt to that need. Anyway.
Jess, did you want to comment at all on this particular topic?
Yeah, just in relation to what RT just said, job security at this stage in my career as a PGY2 hasn't really crossed my mind going forth. Obviously, as I've highlighted, not on any particular training program. And certainly for some certain specialties, I am aware that there are limited job opportunities. But given this discussion is all about workforce issues and demand and the need for rural journalists and rural GPs in Victoria, I don't see job security being an issue in terms of that sense, just in terms of potentially if there's a certain place that I particularly want to work, then that's something. But yes, job security is something that hasn't crossed my mind at this point.
Thanks, Jess. So I appreciate that we're getting towards the end of time. We might just try and squeeze in one last question. We've had a number of burning questions coming through, but we'll just do one last one before we come to the end of our evening. It's from Michael Connellan. Thanks, Michael. Unlike other states such as Queensland, Victoria is really only just starting down the rural generalist pathway. The RG pathway requires more intensive supervision and mentoring, and this is mostly being done by the same doctors who have been supervising medical students and registrars for years now, and are now asked to supervise interns, IMGs and HMOs and extended skills posts and graduates as well. How do we manage over the next few years without seeing more burnout, exhaustion and retirement of the current supervisors? It will take quite a few years to get rural practices filled with competent RG graduates, but can we hang on in the meantime? Any thoughts from the panel?
If you actually model the workforce situation, what's expressed there is that we have worn out our capacity to actually service an appropriate training model going through the system. But it's not all doom and gloom. I think that the enthusiasm that we've seen with some of the younger doctors, and bear in mind that Australian doctors in regional centres are often trained to a fairly high level before they actually come into the rural workforce environment. So they've got skills and expertise there. And so, what we're seeing is, I think within 5 years, we will have a very rapid uptake, so long as the Commonwealth Department of Health allows it. I mean, I don't see this as a pilot. I see this as a solution that we're doing in the Murrumbidgee, that I think we can all look with a lot of positivity around it. So I'm pretty optimistic with the quality and the motivations that are coming through. We've just got to give that quality and motivations the right framework in a professional, structural sense and an industrial sense to work towards, so they see the benefits of it. you know, capital will follow opportunity. And I think if we create that opportunity, then we'll start to see investment into these sort of areas. The other thing that I think, you know, we are limited because people continue to see the solutions and the problems to workforce or general practice through the prism of Medicare. As long as we continue to see that through that prism, then we won't get anywhere. You know, and what we've shown tonight is that diversity of a whole range of things and flexibility is what's required in any of these, you know, model environments, because, you know, you can't just create an item number that's going to solve this issue.
Thanks, Paul. Would anyone else like to comment before we wrap up for the evening?
Yeah, I'll comment, Scott,
Yep.
because I talk about everything. Listen, I agree with Paul, but I guess in response to the supervision directly, we had RG and non-RG doctors at Kinguroy. It was a real generalist model, but actually my star, the best doctor I ever had, did not come through the real generalist pathway. She wasn't a real generalist. She was RAC GP. I don't think she even had FAR GP. But we had supervision for both, and I didn't find the supervision more intense for one group or the other, or more difficult. I think people who came out for training were well prepared for training and did require supervision and mentorship, but I didn't find that one pathway was more intense than the other as far as what my requirements were for their supervision. And particularly when we did it as a community, so it wasn't just me. You know, it was the practices in town. The supervision was not so onerous, and oh my goodness, the payout was incredible. I mean, we end up with a great team and a great colleague, and I don't think it's as onerous as maybe as it sounds.
I'd second that, RT. I'd say, Michael, I'd be thinking, share the supervisory load as much as possible. Be honest with yourself about what you're able to do as a supervisor, and outsource and delegate as much as is reasonable to your competent colleagues. I'm sure doing so as fairly as possible, and then also just, I guess, engage with the other training providers to help them carry the load together, and give us feedback. For example, at Rural Doctors at ADAV, if something's not working in your local health service, if you don't have enough capacity to supervise, if you don't have enough senior doctors, so we can then advocate for you, because if we don't hear firsthand from your experiences, then we can't advocate as effectively.
Thanks, Rob. All right, I'm mindful of the time. It's been a good evening, but I might ask each of the panelists to just give us their quick one-sentence takeaway from the evening. What's your pearl of wisdom? We'll start with you, Rob. What would you say?
I'd say, as you can see tonight, there's a huge variety of people involved in rural medicine. There's a great diversity of experience and possibilities out there. If you're trying to solve a problem, chances are somebody solved it elsewhere already. Come along to conferences such as RMA, you'll find all sorts of rural generalist characters there, and you'll find all sorts of solutions to your problems. Junior doctors come along as well to our conferences when we can go to conferences again. It's a fantastic world out there.
Thanks, Rob. Jess?
Sorry. I think, just always these meetings, these Zoom conferences just always reinforce to myself the possibilities of rural medicine. And I think there's a lot to be positive about despite all the workforce issues from tonight.
Thanks, Jess. Therese?
I would say that engage with management where you can, the management of your health services, because I think you'll find most leaders want the best for their communities, and they're willing to listen. And I think if you provide them with a way to understand how to, I'll use your word that you picked up before, Sky, if you can encourage them to bankroll the future, you'll all be winners.
Perfect, thanks, Therese. Hayley?
Yeah, thanks, Guy, and thanks all for a really insightful conversation tonight. From the RWAVE perspective, for us, we're really looking at how we can promote the towns as a great place to work and the career progression that can be offered through training and upskilling opportunities, we're really looking closely at the place-based solutions and really involving ourselves with the community to try and identify something that will really work and help the GPs to feel supported in the community through those integrations with the community and the training and upskilling opportunities, just to, you know, allow them to feel safe in the quality of care that they're providing the communities and feeling confident in the care they're providing.
Thanks, Hayley. Paul?
Yeah, look, I think there was another part of the Rural Doctors Viable Models project that came about, and that was to show the difference between rural practice and general practice. And there's been a generational debate about, you know, is rural practice part of general practice, or are they separate with intersecting? Now, in my opinion, we're only going to go forward if we accept the difference, intersect, because general practice in the cities, unfortunately, because of the structural things and the pressures on those doctors, is really in a big ball going down the hill. You know, only 15% of people want to actually do general practice anymore. And so it's got a lot of problems. Now, if we're just a ping pong ball in this domain of general practice, then we're going to roll down the hill with it. But if we differentiate ourselves, look at different solutions to the issues, then I think we've got a very, very positive future in rural areas.
Thanks, Paul. And RT, what would your final pearls of wisdom be for the evening?
Sure. Listen, I guess the main thing is, I think when you're looking for care for your community, you can't change your target. That's got to be your target. But I would just say, we've heard so many different solutions. Don't be rigid. Don't be fixed on a solution, but be flexible and be open. And then subpoint, love your team, nurture your team, care for your team, and you can get to your target.
Perfect. Thanks, RT. So I'd like to thank all of the panelists for giving up their time this evening for this discussion. And I'd really like to thank all of you for attending or watching this later online recorded. And thank the RACGP as well, who actually have supported this session to run this evening. The next session that we'll be running in the VRHC Speakers Series next month will be Rural Mental Health Services, and it's scheduled for the 27th of July. So we'll email the registration link so you'll be able to access that readily. An evaluation will also be emailed out to you following this session. Please help us to improve these sessions by completing a very short survey. We promise it's not too painful. And for any junior doctors in the audience, just a reminder that AGPT 2022 final round applications for ACRM open on the 7th of August and will close on the 30th of August. And RACGP will open on the 30th of August. So check their websites for full details. Thanks again, and we hope to see you next month.